Welcome. Good evening, everyone. Welcome to the Kerala Young Gun webinar. We are actually getting overwhelming response to the Young Guns as well as the Next Gen's webinars. So we are seeing a record number of attendance, and it's partly because we are allowing young people to come and present their cases, which in itself is unique, and the cases they present are really worked up. Beautiful images, really rare sometimes. It gives you a unique perspective into and allows for extensive learning when you attend these webinars. So today, the cases chosen again are unique. It's a mixed bag kind of thing, but I'm sure these young guns are going to again keep up to the name of the Kerala chapter. Uh, with this, I would like to welcome uh, Dr. Rima. She would like to talk about the efforts that she's taken to promote and create awareness for the sickle cell disease. Over to you, Dr. Rima.
Thank you so much, sir. And I use this platform of Young Guns today. 19th June happens to be the Sickle Cell Awareness Day, and Society of Fetal Medicine has always been involved in initiative for a social cause. And I take today's day to thank our advisors, and of course, Khurana sir has been the torchbearer in this mission. Dr. Ratna, Dr. Mohit Shah. I would Vanjana has been the backbone of this program, and I really thank her for taking such great efforts to put this program forward. Dr. Deepa Bhatt has been with us to help us take this mission forward. It's amazing. 18 regional chapters, 4,500 members, and each chapter has given such beautiful videos to increase awareness of sickle cell disease. I really compliment. These are the videos that are on our drive. They've been released nationwide, pan India today, increasing awareness about sickle cell disease at the grassroots level as well. A real sincere gratitude from Society of Fetal Medicine to everybody to take this program forward. And it's been an amazing journey with all the state chapters being so involved in this. It appears to be a very small work, but the message it carries is huge, and it definitely will make an impact in the long run. I thank the people who are behind the scenes, Miss Saswati Mukherjee and Mr. Akash, who helped us with the videos, the brochures which are now in regional languages being circulated across the country. A lot of hard work has gone in that. And I again thank all the state chapters, the entire team that got together to make this program a great success. We will be forwarding all these videos to the at the national level to the Ministry of Tribal Affairs regarding the effort that's been put in by all our members as a teamwork in taking this program forward. Sincere gratitude from the Society of Fetal Medicine. I thank each one of you once again for taking this mission forward. I would request Dr. Sinish to now take on the young guns forward. And I think the young guns need to know that we are working for the fetus, and sickle cell can definitely impact our fetus. So this is the day when we need to realize that we need to even work on a wider impact affecting lives of fetuses who are yet to come. Thank you so much. Thank you.
Thank you, Rima ma'am, for the fantastic opening of the session. And thank you all my colleagues who have joined in for this session. It is with immense pleasure that I invite one and all for the Kerala edition of the Society of Fetal Medicine webinar called as a Young Guns webinar, a very thoughtful series of case presentations by young, budding, and enthusiastic fetal medicine specialists, visioned by the Society of Fetal Medicine India. Today, we have arranged a wide array of cases which are navigating through various aspects of fetal anatomy and pathology. The objective of the cases that have been collected in this webinar is to highlight the prenatal diagnosis through various modalities such as 2D, 3D, and color and power Doppler, and their postnatal confirmation so that the prenatal diagnosis is confirmed. This, as we know, enhances the learning curve and sharpens the clinical skills aiding and empowering fetal care. At the end of this webinar, I'm very sure everybody will come enrich out of it. With this short introduction, I hand over the presentation to Guhaprita. She is a fetal medicine. She is a consultant in fetal medicine at Valvanad Hospital, Ottapalam. This is a wonderful city in the Palakkad district of North Kerala. So over to you, Guhaprita.
Thank you, sir. Good evening, everyone. I'm Dr. Guhaprita. I would like to thank SFM team for providing me this opportunity. Today, I'm going to discuss about a case of fetal hypospadias. Mrs. X, a 23-year-old primary gravida, who had a non-consanguineous marriage, and there was no significant medical or genetic history. The only positive history was a history of recurrent bleeding since first trimester, and she was on vaginal micronized progesterone support from 8 weeks till about 22 weeks. And her screening, first trimester screening was low risk, and she had a first trimester scan and TIFA done elsewhere, which were found to be normal. She was referred to us at 30 weeks and 4 days in view of fetal growth restriction. And when the scan was done here, the fetus was growing small for gestational age. The fetus growth was at second centile with normal Dopplers and Leica. Anatomical evaluation of the fetus was done, which was normal except for a short curved penis with a bulbous tip. And when the color Doppler was switched on, the urinary stream was appeared to be arising from the base of the penis, and it was not linear. This is the picture showing a scrotal dome with a short bulbous tipped penis. And in the color Doppler, usually we will get a linear stream from the tip, whereas here it was a widened stream and it was arising from the base of the penis, almost in the penoscrotal junction. This is a reference image at around the same gestational age where we can see the length of the penis and a linear jet from the tip of the penis. This is again a clip showing the same features. We can see the fanned out urinary stream. And in the 3D image, we can see that the scrotum appears normal with a short and stout penis. So a diagnosis of midshaft variety of hypospadias was made, and the findings were explained to the parents. And in view of FGR and hypospadias, they were advised for a genetic testing. Anyway, they denied the testing and they came for FGR follow-up. The growth was maintained at third centile with normal Dopplers. So she was carried on till 37 weeks. Then induction of labor was done and she had a normal vaginal delivery with a male baby of weight 1.8 kg. Postnatally, the baby had a small and ventrally curved penis with absent ventral hood of prepuce, absent ventral prepusal skin, and the urinary meatus was situated on the ventral surface of glans instead of the tip of the glans. So this was consistent with glandular hypospadias, which is a most distal variety. And a pediatric surgeon advised them to bring back the baby at 1 year of age to decide about the surgery. Some theory about hypospadias. It is an abnormal location of urethral meatus along the ventral shaft of penis, scrotum, or perineum. It is one of the most common congenital sexual anomaly of a male fetus with the incidence of around 1 in 500, which is actually it's a common anomaly. It is usually associated with chordae and a dorsal hood of prepuce. There are various types based on the location of the meatus. It is divided into 3 major categories, which is the anterior or most distal variety, which includes glandular or coronal, where the meatus will be situated in the glans, but not at the tip. The second moderate variety is the midshaft variety, where the meatus is situated on the penile shaft, which can be a distal penile, midshaft, or proximal penile. And the last and the most severe variety is the posterior, proximal, or third degree hypospadias, where the meatus is situated in the prenoscrotal junction, scrotum, or perineal. In our case, in the antenatal diagnosis was for midshaft variety, but it turned out to be a glandular variety in the postnatal findings. The etiology for hypospadias is not yet well established. There was a variety of genetic, environmental, and endocrine factors is found to play a role. The major cause was in all these conditions is found to be a low testosterone levels between 8 to 14 weeks of gestation. That is the period of urogenital development. And literature also shows a correlation between FGR and maternal progesterone intake with hypospadias. The urogenital system develops from cloaca, and outer surface of cloaca has a cloacal membrane. This cloaca is differentiated into anterior urogenital sinus and posterior rectum by a urogenital septum. At the same time, this cloacal membrane is also differentiated into anterior urogenital membrane and the posterior anal membrane. On either side and anterior to the urogenital membrane, this mesoderm will proliferate and form two genital swellings and a genital tubercle. Under the influence of testosterone, the genital swellings will develop into scrotum and fuse together in the midline, and the genital tubercle will elongate to form the penis. At that time, when the penis is developing, the urogenital membrane, the midpoint of the urogenital membrane will form a groove, that is the urethral groove. This urethral groove will grow along the undersurface of penis, and this urethral groove will have cells inside and which make it a urethral plate. The edges of urethral plate is the urethral fold. The fusion of the urethral fold with canalization of the urethral plate forms the urethra. So whenever there is a defect in the fusion of this urethral fold, this will end up in hypospadias. Most cases of hypospadias are isolated, but there has been reports which suggest a correlation, which suggest the finding is associated with certain chromosomal disorders, microdeletion syndromes, and also single gene disorders. So it will be wise to advise the genetic testing if we find a hypospadias antenatally. A few points about how to assess a normal genitalia in a second trimester anomaly scan. The genitalia can be better visualized in second trimester. For male, we can identify penis and scrotum. And for female, we can see 4 parallel lines or 2 parallel lines indicating labia majora and minora. For examination, we will go to the infracoccygeal view, like how we look for the PAMC view. From there, go anteriorly, you can see the genitalia, and bring up sagittally to look for the penis and the scrotum. And similarly for the female genitalia, the same view for the PAMC view, go anteriorly where we can visualize the 4 lines corresponding to labia majora and minora. So the findings in hypospadias will be, as explained, a short and blunt tip penis, ventral incurvation of penis with a fan-shaped urinary stream arising from the base. Now the major dilemma will be whether to report this condition or not to report. In our PCPNDT Act, there is a provision for us to use ultrasound and amniocentesis to detect sex-linked disorders. But still, as there was a dilemma regarding this condition, for this patient, we wrote up to the district PCPNDT office before revealing the diagnosis to the couple. The symptoms of hypospadias will be abnormal urine stream, including spraying and dribbling, sexual dysfunction, and psychological and emotional effects. The management mainly is the surgical repair, which is usually performed between 6 to 18 months, which includes various corrections like penile correction, urethral correction, glans correction, and cosmetic penile skin coverage. Minor cases without symptoms with a normal urinary stream may not require a correction. Late repair in adulthood has higher rate of recurrence and complications like ureterocutaneous fistula. So if a surgery is planned, it's ideally done in the young age. So my take-home messages are simple. It's always better to include genital examination in our routine DIFA scans. And whenever there is a doubt, we can use color Doppler to look for urinary stream. That will give a apt diagnosis of hypospadias. These are my references. Thank you.
Thank you, Goprita, for this wonderful presentation. Abnormalities of genitalia are perplexing and a dilemma. in the back, and especially in the background of PCP and DT Act. We do have already certain questions, but we will be addressing those questions at the end of all the presentations. So
Thank you, sir.
may I hand over the presentation to Dr. Shruti Soman. She is a young fetal medicine specialist. Currently, she is an assistant professor at Amrita Institute of Medical Sciences, Kochi. So welcome, Shruti.
Good evening, all. Thank you, sir, for that introduction. So today I'll be presenting a case which we encountered in our OPD a few weeks back. So this was a 23-year-old. So this was a 23-year-old third gravida. It came to us at 20 weeks and was referred as fetus with a posterior fossa cyst, query dandy Walker malformation. Her obstetric history included previous term LSCS and a previous history of miscarriage. There was no other relevant past medical or family history. Coming to the present pregnancy details. So this was a spontaneous conception and a first trimester scan was done at 13 weeks and 4 days, which showed no abnormalities. She had not done any aneuploidy screening. All her antenatal visits were done abroad, and she came to our OPD with her last scan, which was done at 19 weeks and 2 days, which was showing the posterior fossa cyst. So we did a scan at our center, and that was done at 20 weeks. We saw that the head circumference was at +4 standard deviation. All other biometric parameters and the fetal Dopplers were normal. On looking at the anatomy of the fetus, we saw, this is the real-time clip of the axial section of the fetal brain. Here we saw that the posterior 2/3 of the fetal brain was covered with a cystic lesion with internal echoes inside, and the rest of the fetal cerebral parenchyma was pushed anteriorly. We could see a part of the interhemispheric forks and few features suggesting ventriculomegaly. Apart from this, rest of the intracranial anatomy was not clearly delineated. So these are the other sections. This is the sagittal section and coronal section showing the same features. We can see in the sagittal section, we can see how the cerebral parenchyma is pushed anteriorly, and there's evidence of ventriculomegaly also. Yeah. Now, on switching on the color Doppler, we saw that there was increased vascularity around the cystic mass. So we were thinking this could be a dural sinus, and the increased vascularity surrounding the dural sinus could be a arteriovenous shunt. So this was evidenced on further imaging. We saw that in the sagittal and the coronal sections, we could see jets of arterial feeders into the cystic lesion. So there was some arterial feeder which was communicating or draining into the cystic lesion. So this was evidenced by a spectral Doppler also. Here we can see this was some subcutaneous arterial vessel, which was evidenced by the spectral Doppler here, and that was traveling in the subcutaneous plane and draining, giving off an arterial feeder into the cystic mass or the dural sinus. There were other features of hyperdynamic circulation as well. There was cardiomegaly, there was tricuspid regurgitation, and we could also see dilated superior vena cava. So we came up with the diagnosis of torcular dural sinus malformation. Torcular because it was seen in the posterior part of the head, and torcular is the most common site of dural sinus malformation. It was seen with an AV shunt, with multiple AV shunts, and with signs of volume overload and impending cardiac failure. So we were, since the lesion was quite huge and we were not very sure regarding the prognosis, we counseled the family for a fetal MRI for further delineation of the intracranial anatomy. And the MRI report was no different. They also reported the same thing what we had reported in the fetal ultrasound. Here we can see that actual in the sagittal section, we can see that this was the posterior dilated dural sinus, and these are the coronal images showing the blooming artifact, signifying that there was some slow flow inside. So this was the MRI report. intracranial vascular malformation, query dural sinus origin, occupying most of the supratentorium, displacing the cerebral parenchyma with cortical thinning. Interhemispheric forks visualized, and remainder of the midline structures were not well visualized. So we thought of, because we were not sure regarding the prognosis, and we planned for a repeat ultrasound after 3 weeks. And there was no reduction in the size of the lesion. In fact, the size of the lesion had increased, and there was cardiac hypertrophy of the cardiac muscles, and there was pericardial effusion also with tricuspid regurgitation. So from this, we concluded that the prognosis was not very good, and we counseled the family regarding the same, and they opted for medical termination of pregnancy. Since the patient had a previous cesarean section, in order to give her a trial of labor to reduce the maternal morbidity, we gave them an option of cephalocentesis in order to reduce the size of the lesion. And we also discussed regarding the remote chance of recurrence of this lesion and genetic association, and we also counseled them for a fetal autopsy. So this is the clip showing cephalosynthesis almost starting of the procedure, and this is post procedure, and we drained almost 2 liters of blood while doing the cephalosynthesis. They proceeded on with the medical termination of pregnancy, and this was the fetus. You can see the huge mass over there. There was a little bit of placentalomegaly also. We have sent the fetus for autopsy, and the reports are not yet out. Coming to a little bit of anatomy about the dural venous sinus. So dural venous sinuses are channels within the durameter that drain blood from the brain. So coming to the major sinuses, the major sinus one is superior sagittal sinus. Then we have the inferior sagittal sinus, which via the straight sinus drains into the torcular. Torcular is basically the confluence of the sinuses. And from the torcular, we have 2 paired sinuses, that is transverse sinus, which again joins, which drains into the sigmoid sinus, which finally drains into the internal jugular vein. Now, in the fetus, these sinuses begin forming during the first trimester, and they continue maturing throughout the gestation. Now, what is dural sinus malformation? Dural sinus malformation is basically massive dilatation of one or more of the dural venous sinuses. And these are extremely rare congenital malformation, accounting for less than 2% of the fetal vascular related malformations. Coming to the pathogenesis is still unclear and debatable. We went through few papers and articles and review of literature, and we have come out with a theory what we have understood from these papers. So there's faulty remodeling of the embryonic venous plexus, and this leads to abnormal development of the dural sinuses. And these abnormally developed dural sinuses turns into a giant dilated pouch-like sinuses. Now, these abnormally developed dural giant huge sinuses, they may or may not be associated with the AV fistula. And even if there is an AV fistula, the caliber of the arterial feeder and the velocity through which the blood is going into the sinuses could be variable. So if in case the dural sinus malformation is associated with an AV fistula, if the fistula is large, or if the velocity of the blood flow is high, then the dural sinus malformation tends to be larger, and there could be hyperdynamic circulation. But in case if the fistula is small, or if there is no AV shunt at all, then obviously there is no much of blood flow into the dural sinuses, and it tends to be smaller and may spontaneously close or resolve in the course of time. In either of the cases, because there is venous stasis and turbulence of flow and abnormalities of the walls of the sinuses, there's a high chance of thrombus formation. And what happens when there's thrombus? If the thrombus forms at the region of arterial feeder, that means if it forms at the region where the artery is communicating to the sinus, it causes occlusion of that flow, leading to the regression of the dural sinus malformation. But If the thrombus forms or occludes the major sinuses, the outflows of the major sinuses or torcular, it will impair the normal venous drainage and will cause upstream venous congestion, venous infarction, hemorrhage, and obstructive hydrocephalus. So the long-term neurological deficit will depend on the location and the size of the thrombus, the presence of infarction or hemorrhage, and the duration of the venous obstruction. So this was in a paper, a systematic review published in 2020. They had included 31 studies, including 78 patients. I'll read out the conclusion part. They found out that 10% of the dural sinus thrombus cases experience an in utero or neonatal death, 10%. And the one that survive, the majority of cases, they reduce in size or completely resolve. And they say that 85% are reported to have a good outcome. The ones that survive and the ones that show regression or reduction in the size of the thrombus. However, further evidence is still needed regarding the long-term neurocognitive delay. They say that the ones with a progressive ventriculomegaly or progressive increase in size of the thrombus, even if they don't undergo intrauterine death, still the postnatal prognosis is not that good. Kids may have a speech delay or developmental delay. These have been reported. This is another paper wherein they have used something called as Dixon-based MR angiogram to delineate the intracranial angioarchitecture. They have used this MRA to know which is the arterial feeder that is supplying the dural sinus malformation. And this is the only paper I saw wherein they had used this technique. So coming to the take-home points, evolution and prognosis of dural sinus malformation is variable, and spontaneous reduction is seen in 97% of prenatally detected cases, more so in cases with a non-arterialized and or the ones with a small shunt in dural sinus malformation. Arterialization is seen in 36% of cases, which can be demonstrated by using a color Doppler or a spectral Doppler. And spontaneous reduction or recanalization of the sinus is generally associated with a favorable outcome. Now, coming to the poor prognostic factors, the ones with a high velocity blood flow are the ones which shows signs of volume overload, failure of regression or increase in the size of the thrombus over the course of the time, presence of parenchymal infarctions, and hemorrhage and hydrocephalus. These are my references. Thank you for the patient listening and thank you for the opportunity. Thank you, sir.
Okay, may I please invite Dr. Basil Matthews to share his presentation?
So can I start?
Yes, please. Yes, Dr. Basil.
Yes.
Please introduce yourself.
Well, sir, myself, Dr. Basil Matthews. I am the clinical head of Department of Fetal Medicine in Rajagiri Hospital, Alua. First of all, I would like to extend my sincere gratitude to the SFM team, to my mentor, Vivek sir, to Sinus sir, Ashok sir, Alok sir, Jyoti ma'am for giving me this opportunity, as well as they have been behind me, guiding me to present over here today, and all my efforts have been supplemented by their effort as well. Thank you for the opportunity, and I will be talking on congenital partial portal agenesis. Now, this was a case that I had to deal recently in our OPD. And to understand this particular scenario, we need to understand the normal anatomy of the portal system. The normal umbilical portal venous system, it consists of umbilical vein, portal veins, ductus venosus, superior mesenteric vein, splenic vein, and inferior mesenteric vein. Now, what is the function of this umbilical portal venous system? As we all know, this is to deliver the high oxygen and nutrient-rich blood from the placenta into the baby, particularly through the ductus venosus shunted into the left heart and thereby into the fetal brain. So what happens in case of partial portal agenesis is when there is an aberrant remodeling of the vitelline system, that is when portal or partial portal agenesis that happens. Now, to understand that, we will go more into the normal anatomy. If you can see over here, this is that the umbilical vein starts from the placenta. It accompanies the umbilical artery and it enters the fetus at the level of umbilicus. Once it enters the fetus, there is a small, short intra-abdominal part of the umbilicus, and once it enters the liver, it will become the left portal vein, and this left portal vein joins with the main portal vein, and it continues as the right portal vein. And this left portal vein, after joining, it continues as the ductus venosus. So if we can have a look over here, the umbilical vein is coming, entering the baby, continues as the left portal vein. It is giving off 3 branches of the left portal vein, and then at this juncture, portal sinus, it is joining the main portal vein, which is the red, which is coming from down below. And once it joins at the level of portal sinus, this is continuing as the right portal vein, and right portal vein is divided into anterior and posterior branches of the right portal vein. Now, if you can look closely, you can see that the left portal vein, after joining at the junction at the portal sinus, it is continuing as the ductus venosus. If you go further down, you can even see the splenic vein coming and joining the superior mesenteric vein to become the main portal vein. This is particularly or characteristically called as the X sign of the normal duct or normal portal system. So it would be a good practice to image a normal portal system. For reference, this is a normal case with labeling. There's an umbilical vein. There are 3 branches of the left portal vein, and then there's the characteristic X system. Now, as I said, left portal vein, there are 3 branches. The first one being the inferior one, the middle one, and the superior one. And beyond that, you can even see the hepatic veins, 3 hepatic veins joining the IVC. Now, the same has been depicted here again, umbilical vein coming and joining and continuing as the left portal vein, giving off the 3 left branches, continuing as the ductus venosus, and the main portal vein, as I said, is formed by the splenic vein. This is a splenic and superior mesenteric vein coming from down below, splenic vein coming from the spleen, joining to become the main portal vein. From main portal vein, it joins at the level of portal sinus, and it continues as the right portal vein, and right portal vein divides into the anterior and the posterior right portal vein. Why am I emphasizing on this particular anatomy a lot is because in our case, this anatomy was distorted, and I want you to be clear with the normal anatomy. Right portal vein, as I said, branches into 2. Here, again, the same has been depicted. Now, coming to our case, this was a case, 36-year-old, multi-gravida at 20 weeks of gestation. For a routine morphology scan, her ANC antenatal care has been a low risk one, and NIPT has been reported as low risk. Now, if you can see in this particular case, you can see that the umbilical vein is coming. It is continuing as the left portal vein. It is giving off its branches, and if I can have your attention over here, it is giving off its first 2 branches or at this juncture, and it is giving its 3rd branch at this juncture and continuing as the ductus venosus, which is joining the hepatic veins into the IVC. And when you go further down, you can even see that there is a splenic vein coming and joining the SMV and continuing as a right portal vein, which is going and supplying the right side. But when you look closely, there was no communication between the two. So again, the same thing. This is our case in which the umbilical vein coming and continuing as the left portal vein, it is giving off its left portal inferior branch, middle branch, superior branch, and continuing as the ductus venosus and entering at the level of infundibulum into the IVC along with the hepatic veins. And you look down below, you can see the splenic vein coming and joining the superior mesenteric vein into and forming the right portal vein, but there was no established communication between the two. So we labeled this as partial portal agenesis, but at some juncture, we had seen that there was some communication between the main portal vein and the inferior vena cava. So whenever there is a portal and systemic connection, we call it as extrahepatic portosystemic shunt. It was a type 2 Abernathy malformation. This is what the initial diagnosis was. Towards the late gestation, the same has been explained, depicted again, wherein you can see that there is no established connection between the left system and the right system. To compare, for a normal cases, as it been shown previously, the main portal vein which connects into the left portal vein at the level of portal sinus and continues as the right portal vein. Here you can see that these two systems are entirely disconnected. Now, just a couple of words on the embryological origin of the portal system. It derives from the three paired systemic veins, which are the umbilical veins, vitelline veins, and the cardinal veins. The umbilical veins, they run along the septum transversum, and vitelline veins, they pass through the sinus venosus, in which the hepatic sinusoids will be forming, and there will be critical anastomosis, which forms between the umbilical veins and vitelline veins, leads to structures such as hepatocardial segment of IVC and main portal vein, which is a part developing from the dorsal anastomosis. And in case of umbilical vein remodeling, the entire right umbilical vein and cranial left umbilical vein, it degenerates, and the caudal left UV pulses and connects to the portal system via the ductus venosus. So to summarize, the main portal vein again is formed by the dorsal anastomosis of the vitelline veins, and left portal veins via the persistent caudal left umbilical vein and ductus venosus between the left umbilical vein and the IVC. Now, what could be the cause in our case? Probably could be because of the failure of the dorsal anastomosis, because that is what which establishes the MPV, main portal vein to left portal vein connection. Now, just a word on the hepatic shunts. What is a vascular shunt? Vascular shunt is a shunt that redirects or bypasses the blood, bypasses the target organ. So when what is a hepatic shunt? Hepatic shunt is when the vascular shunt is there that bypasses the liver, which is pretty rare. It happens once in 30,000 to 50,000 live births. It could be an intrahepatic one or an extrahepatic one. Extrahepatic is when the shunt is happening outside the liver. There are mainly mainly two types of extrahepatic photosystemic shunts. This is basically by the Morgan and Supernus classification. There's type 1 and type 2. Type 1 is when, as you can see, the portal system is completely disconnected from the liver and enters straight into the IVC. Here, the difference between type 1A and 1B is the splenic vein and the superior mesenteric vein enters separately. And in type 1B, they both join to form the portal vein, and the portal vein enters the IVC. Now, these two are otherwise called as the Abernathy malformation, or the type 1 is otherwise called as the Abernathy malformation. So as you can see, there is no normal portal anastomosis within the liver, and this definitely carries a poorer prognosis. On the contrary, type 2 has a portal system which is well established, but there is some communication between the portal system and the IVC. This is in addition to the normal portal systems, and hence this carries a favorable prognosis. And depending on the shunt size and the postnatal outcomes, this might require some level of ablation. Now, what about intrahepatic ones? The normal portal anastomosis will be developed, but if you can see on the left, you can see there is a small communication which is bypassing the proper liver proper. So in those on those accounts, even ductus venosus could be considered as a intrahepatic portosystemic shunt. Now, coming back to our case, in our case, umbilical vein was normal. It was entering the liver normally, continuing as the left portal vein, giving off the 3 branches. And till then, everything was normal, but it was continuing just as the ductus venosus and entering into the IVC, and there was no communication between the main portal vein. Missing findings, no anastomosis, as I said, and portal venous supply to the left lobe of the liver was only from the umbilical vein, and MPV RPV axis was isolated. This is just a schematic diagram for your reference, in which this is the normal one. On the left is the normal scenario in which they join the main portal vein. Main portal vein joins the portal sinus, and into the right continues as the right one. But over here in our case, you can see these two were completely disconnected. Our baby, baby had a term emergency LSAS in view of breach, and it was 2.7 kg. Baby was stable at birth. Now, immediate postnatal, we have done the ultrasound. Ultrasound findings were exactly the same as antenatal findings, except for the small shunt which was observed at 20 weeks, which was not observed beyond that gestation. And the liver function and the ammonia levels were normal at birth. Repeated day 3 and day 5 and at discharge, all were normal. Since it was normal, the baby was asked to be on close follow-up. 1 month, again, same, stable, ammonia was normal, liver function was normal. And what happened to the ultrasound at 1 month? Intrahepatic biliary radicals, normal, main portal vein, normal, right portal vein, normal. But the left portal vein was not clearly seen. There was a small branch arising from the main portal vein to the left lobe, which could be a left portal vein. The exact delineation of the vascular anatomy is not done. Hepatic veins have been normal. There is no evident portosystemic shunt at present. So on points, we should consider portal system screening by obtaining an oblique transverse view. How to get that? So this is the view in which, like when I showed you initially, the umbilical vein entering the liver, and then you continuing as the DV. So that particular view can be obtained at this particular axis. And if you tilt it slightly caudally, angle it slightly caudally, you will get get the plane in which you can delineate the characteristic X shape in which the main portal vein is entering, and continuing as the right portal vein, and then dividing into the anterior right and posterior right. Now, as far as the portal system is concerned, you should consider anomalies beyond these classically described UVS, umbilical vein systemic shunt, the ductus venosus systemic shunt, and portal shunts. And there could be abnormalities other than these. Abernathy malformation is just the type 1 congenital extrahepatic portosystemic shunt. They have got a very poor prognosis, especially because there is no portal system, developed portal system, portal anastomosis within the liver. It is completely bypassing the liver, so the baby will have hyperammonemia. Again, the monitoring is with weight gain and ammonia. If it is normal, you can just continue the follow-up. If it is abnormal, you have to think about if there is any vascular anastomosis, and how to delineate the vascular anastomosis. CT triple phase, that is the one that can help in delineating the anastomosis. And if there is a significant anastomosis, then definitely consider ablation. Thank you.
Thank you, Basil, for this wonderful presentation. Sharp observation and wonderful pickup in an otherwise normally looking vascular anatomy at the AC plane. I think it would have been easily overlooked by many, and beautiful depiction of the portal vascular anatomy also. An excellent discussion. So before the next presentations, we have some questions for you also waiting, and we will take at the end of all presentations.
Thank you, sir.
And before we take up the next presentation, we have a short break for the trade partner videos. Thank you, everyone. Now we are back with our presentations. And next, I invite Dr. Sumya to present her case on a prenatally diagnosed case of pyloric atresia. Dr. Sumya is a consultant in fetal medicine at Leila's Hospital and visiting consultant at Shanti Hospital and Saima Redapal. Over to you, Sumya.
Is my presentation visible, sir?
Yes, very much.
Okay, sir. Good evening, everyone. We have seen a few rare and fascinating cases till now. I would like to present a case that is clinically straightforward, yet rare in its occurrence. A 38-year-old female, G3P2L2. NT scan was done elsewhere. Her first trimester combined screening test showed low risk. There was no significant medical or family history. She came for a FIFA scan to us at 22 weeks and 6 days of gestation. Her TIFA scan seemed to be normal. There were no gross congenital abnormalities detected. Heart seemed to be normal. The stomach, bladder, kidneys, etc. seemed to be normal in size. So we sent a normal report and asked her to come back for a growth scan at 28 weeks. She came back at 34 weeks and 6 days with abdominal distension and breathlessness. We did a growth scan. Again, her growth parameters were normal and all the Doppler parameters were within normal limits. There was polyhydramnios. The AFI was 30.6 centimeter and the single deepest pocket was 9.2 centimeter. There was a single large oblong cystic lesion within the abdomen without any internal vascularity. The cyst was seen separately from the bladder as well as the kidneys. Stomach was not visualized separately, but there was no double bubble sign. Fetal movements as well as breathing was normal. There was no obvious facial deformities. Heart seemed to be grossly normal, but the fetal heart rate was consistently in between 110 to 120 beats per minute. So we gave a report as an anechoic cyst measuring 43 into 42 into 80 mm seen in the fetal abdomen on the left side with no remarkable Doppler signals. The cyst was independent of gallbladder, kidneys, and urinary bladder. The stomach bubble was not visualized separately and the distal bowel pattern appeared to be normal. Polyhydramnios was present and a diagnosis was given as pyloric stenosis or atresia with gastric outlet obstruction. Due to fetal bradycardia and maternal distress, an emergency C-section was done on the same day. The baby was kept in the NICU. A gastric aspiration was done and about 250 ml of fluid was aspirated. This was the first X-ray we took on the left side. It shows that there is a single stomach bubble seen. There is no distal bowel gas seen. Baby was kept in the NICU and 24 hours later, we repeated the X-ray because the baby was showing progressive abdominal distension. Again, the same finding was noticed. There was only a single bubble, but the size had increased now. So we referred the baby to a tertiary center where they made a diagnosis of pyloric atresia. Surgery was done, a laparotomy with pyloric web excision, gastrostomy, feeding gastrojejunectomy, and pyloroplasty. This was a baby. This is a picture of the baby about after the first surgery after he was discharged. And the second picture is about after 1 month. A few words on pyloric atresias. Pyloric atresias are rare but well-documented forms of gastric outlet obstruction. The exact etiology is unknown. It is usually sporadic, but an autosomal recessive inheritance pattern is displayed in those with a familial predisposition for pyloric atresia. This is an extremely rare anomaly. Precise rates have not yet been established in medical literature. It accounts for less than 1% of all intestinal atresias. It may either occur as an isolated anomaly or along with other congenital defects. And when it is diagnosed in neonates, the characteristic symptoms are non-bilious emesis and distension of the upper abdomen soon after birth. It is usually due to failure of normal recanalization of the fetal pylorus as a consequence of developmental arrest or a vascular insult between the 5th and 12th weeks of gestation. There are 3 types of pyloric atresia. Type 1 is when there is a pyloric membrane or a web which is blocking the opening. Type 2, when there is a solid cord or a fibrous tissue is replacing the pyloric canal. And type 3, when there is complete discontinuity or a gap between the stomach and the duodenum. These are the 3 types wherein type 1, we see a pyloric web that is obstructing the canal. Type 2, when there is just a fibrous tissue or a cord between the 2 ends. And type 3, when there is absolutely no connection between the 2 ends. So clinical presentation, prenatal presentation is usually with maternal distress and polyhydramnios, and which is usually observed in the 3rd trimester after 28 weeks. Immediately post-birth, the baby will have non-bilious vomiting after the first feeding. And during the first 24 hours, there will be progressive abdominal distension and there is absence of stool passage due to complete obstruction. Without intervention, it rapidly becomes life-threatening as the condition worsens. So how do we detect this case? Antenatally, when we do a USG, we can see distended fetal stomach, usually during the 3rd trimester. Polyhydramnios is often present as a warning sign, and there is absence of dilated intestine distally. Postnatally, abdominal X-rays show a dilated stomach. That is, there is a single bubble. There is absence of distal bowel gas. And upper GI barium studies may show a dilated stomach with complete gastric outlet obstruction and no passage of contrast beyond the pylorus. So MRI will show a persistently dilated stomach without emptying. There is no duodenal or other intestinal dilatation, and MRI can also rule out duodenal or intestinal atresias, as well as it can identify other associated anomalies. Now, the genetic basis, genetic associations and syndromes. As I said, usually we find it isolated pyloric atresia, but in 30 to 50% of cases, there are associated anomalies. And the most common associated anomalies are epidermolysis bullosa and hereditary multiple intestinal atresias. And mortality is more than 50% when there is associated anomalies, but this approaches 100% when pyloric atresia is found with either of these particular entities. I'm sorry, sir, you're seeing my presentation? Yes, okay.
Yes, Soumya, yes.
So, as I said, the most common the associations are epidermolysis bullosa and hereditary multiple intestinal atresias, which has a very high mortality rate. Other associations are urinary tract malformations and skeletal system abnormalities, which can cause arthrogryposis or joint contractures. And when this pyloric atresia is associated with epidermolysis bullosa, it's called the EBPA syndrome, and it has identified genetic mutations like the ITGA6, ITGB4, and PLEC1. The treatment includes surgical intervention with pyloroplasty, with gastroduodenostomy or gastrojejunostomy. It is usually required within days of birth for survival. Postoperative care includes intensive monitoring and nutritional support. So the key points are congenital pyloric atresia is one of the rarest obstructive GI anomalies in newborns. Every case requires urgent specialist attention. Prompt diagnosis and surgical repair is essential for survival, and any delay can increase the mortality risk. Genetic counseling is vital for families, especially with EBPA. Isolated pyloric atresia has a good prognosis with surgical correction, but when it is combined with other anomalies, the prognosis is very poor and long-term follow-up is needed for survivors. Now, a few diagnoses to be considered when we see an abdominal cyst. In GI tract, we should consider obstructive GI lesions, meconium pseudocyst, hepatic cyst, choledochal cyst, splenic cyst, pancreatic cyst, as well as cloacal anomalies. Urinary tract, renal cyst, multicystic dysplastic kidney, hydronephrosis, dilated upper pole in a duplex kidney, dilated ureter or bladder or urethrocoel. And in genital, the ovarian cyst, hydrocolpos, hydrometrocolpos, and even umbilical vein varix can also present as a cystic lesion of the abdomen. I'll be elaborating on a few conditions. First is the esophageal atresia. It shows a small or absent stomach in the presence of polyhydramnios at more than 25 weeks of gestation. If there is an associated tracheoesophageal fistula, the stomach may look normal. Esophageal region shows dilatation of the esophagus with a tapering distal part. Direct visualization of filling and emptying of the proximal esophagus can be seen with fetal swallowing. Duodenal atresia, we usually see the double bubble sign due to an enlarged stomach and a duodenal cap. The duodenum is not usually filled with fluid, so the presence of a fluid-filled duodenum suggests duodenal atresia. A connection between the two fluid-filled structures must be demonstrated because foregut duplication cysts and other abdominal cysts also simulate the appearance of a double bubble sign. This is again usually found at more than 24 weeks of gestation, and polyhydramnios is also present in more than 50% of the cases. Jejunal atresia, usually multiple dilated bowel loops are seen, more than 7 mm in diameter and with more than 3 mm mural thickness with intense peristalsis, usually seen more than 24 weeks of gestation associated with polyhydramnios. And in cases of perforation of the bowel, ascites and meconium peritonitis may be seen. Increased echogenicity of the bowel may also be present, especially when the fetus is affected by cystic fibrosis. Mesenteric cysts usually represent obstructed lymphatic drainage. Fluid contents may be serous, chylous, or hemorrhagic, and usually presents as multiseptate or unilocular midline cystic lesions of variable size. Sometimes a solid appearance may be there, which is secondary to hemorrhage. Choledochal cysts usually represent cystic dilatation of the common biliary duct. The diagnosis may be made by demonstration of a cyst in the upper right side of the abdomen, and there is a communication between the bile duct and the cyst. Absence of polyhydramnios or peristalsis can help in differentiating this condition from other bowel disorders. Posterior urethral valve, the main findings are usually bilateral hydronephrosis, a dilated bladder with a thickened wall more than 3 mm, dilated posterior urethra, which shows the keyhole sign, and oligo or anhydramnios can also be present. Again, ovarian cyst. Ovarian cyst usually presents as unilocular cyst, sometimes containing a daughter cyst in the abdomen of the female fetus, more than 26 weeks of gestation. If the cyst undergoes torsion or hemorrhage, the appearance may be complex or solid, and rupture can result in ascites. Large ovarian cysts can also cause polyhydramnios due to compression of the bowel. So to summarize, though difficult, it is important to establish the origin of an abdominal cyst. Always look for information towards a possible diagnosis like location of the cyst, sonographic appearance, associated anomalies, gestational age, fetal sex, and whether it is associated with oligo or polyhydramnios. In case of obstructive GI pathologies, without prenatal diagnosis, accurate diagnosis after birth might be delayed, and complications including intestinal or gastric perforation or aspiration pneumonia can result from delay in diagnosis, and this can be fatal. The role of prenatal diagnosis is very important. When in doubt, fetal MRI is always helpful, and postnatal follow-up is always indicated. So this is a picture of our baby. Now he is at 5 months. All the feeding tubes has been removed. He is tolerating oral feeds very well, and developmental milestones have been so far normal. So in conclusion, early prenatal detection of such conditions has the potential to significantly improve the outcomes. And I sincerely thank you all for your attention and patience.
Thank you, Sumya, for a wonderful presentation. Abnormalities of dynamic structures like stomach is always challenging, isn't it? And thank you very much for going into the depth of an unusual prenatal anomaly. And we would take up the questions at the end of the presentations, all presentations. Next, I would like to invite Dr. Divya Pillai. She is a consultant in fetal medicine at Rajagiri Hospital in Kochi. She'll be presenting a case of recurrent bilateral schizencephaly. So over to you, Divya.
Is my screen visible, sir?
Yes, very much.
Good evening, everyone. I'm Dr. Divya. I'm working as a consultant in fetal medicine in Rajagiri Hospital, Alua. I would like to thank the SFM team for giving me this opportunity to present a case on this platform. So today I'll be presenting an interesting case of recurrent bilateral schizencephaly. So, 21-year-old Gravda 2 presented at 31 weeks of gestation for second opinion regarding open lip schizencephaly. Her NT scan was reported to be normal, and first trimester screening was also reported to be low risk for aneuploidies. Anomaly scan done was reported to be normal. Interestingly, her first pregnancy was electively terminated at 22 weeks of gestation in view of multiple anomalies, which mainly included septal agenesis, open lip schizencephaly. Amniocentesis was done during that pregnancy, and chromosomal microarray report was said to be normal. So on detailed ultrasound evaluation, on detailed brain evaluation, we could see that there was a large defect, bilateral defect in the brain parenchyma with a cleft with communication with the lateral ventricles extending into the brain surface. This is the large cleft that we can see. This is another image showing the presence of a large cleft communicating to the brain surface. Here is a video wherein we can see mainly absent septum pellucidum and large bilateral cleft involving mainly the frontal and the parietal region. Also, thalamus and the posterior fossa structures appear to be well differentiated. On sagittal section, we could see that the corpus callosum was present and also it appeared to be thinned out, but it was of normal length for the period of gestation. Rest of the scan findings were normal, and we planned for a fetal MRI brain and amniocentesis for whole exome sequencing. These are the fetal MRI brain images. Sagittal section showing a large cleft in the brain parenchymal matter, mainly involving the parietal lobe. This is another coronal section of the fetal MRI, which shows presence of large bilateral cleft in the frontal and the parietal region. This is an image that we could get from her previous pregnancy ultrasound image, wherein we can see that there is absent septum pellucidum and presence of a Blake spout cyst, and also there was a large defect in the brain parenchymal matter. This is the prenatal aneuploidy test QFPCR analysis report of this pregnancy, which showed that it was negative for trisomy 21, 18, and 13. Whole exome sequencing report showed that there was a variant of unknown significance of heterozygous state in PEX13 gene. So the couple was informed that the prognosis could be poor due to the lesion involving both the hemispheres and being of the open type. In view of potentially poor prognosis, the couple opted for termination of pregnancy. However, the medical board did not permit termination of pregnancy as the gestational age had exceeded 24 weeks. So finally, she delivered a live female baby of weight 1.9 kgs at 36 weeks of gestation. This was the postnatal imaging done, and this also shows the presence of a cleft in the parietal region, thus confirming the prenatal diagnosis of schizencephaly. So on postnatal follow-up, the baby is now 1 year old with delayed milestones and motor developmental problems. So schizencephaly is actually a rare congenital neuronal migration disorder, which is characterized by a cleft lined by gray matter connecting the surface of the cerebral hemisphere to the lateral ventricle. So it is a rare condition with an estimated incidence of 1 in 1 like live births, and it is almost always sporadic, although few familial cases have been described. There is no known gender predilection. Coming to the types of schizencephaly, there are mainly two types. One is closed lip type, wherein the clefts are fused or in contact with each other, and it is often difficult to be detected by an ultrasound. And an open lip type, where the clefts are separated and filled with cerebrospinal fluid, and is more easily identifiable on ultrasound. Pathogenesis is not well understood. The most accepted theory is that a vascular insult at the early phase of neuroembryogenesis results in ischemic area in the germinal matrix, preventing the neuronal migration and leading to the formation of cerebral cleft. The size of the cleft would depend on the severity of the vascular insult in the tertiary of middle cerebral artery. Other theories include dysgenesis of the pyramidal tract or a primary neuronal migration disorder. So the cleft usually mainly involves the sylvian fissure, frontal or the parietal lobes, mainly around 70% cases. And there has been association with other CNS anomalies, mainly septo-optic dysplasia, absent septum pellucidum, dysgenesis of the corpus callosum, ventriculomegaly, and cortical dysplasia. So some genes have been found to be associated with schizencephaly. So familiar schizencephaly, mainly EMX2, HHT1, and COL4A1. And non-familiar schizencephaly, SIX3, WDR63, and EFNB1. These are some of the genes associated. Prognosis is like when the clefts are bilateral or unilateral with large cleft, the prognosis is significantly worse. And whereas when it is a small unilateral schizencephaly, they may have a good developmental prognosis, especially when the motor cortex is not involved. When unilateral closed-lip schizencephaly is diagnosed, it is difficult to give a straightforward recommendation and the management should be individualized. So differential diagnosis mainly will be a poroncephaly. Poroncephaly will usually involve cysts within the brain tissue, often communicating with the ventricles or the subarachnoid space. And the cyst walls are usually lined by gray matter of the glial scar tissue. Intracranial cyst will be another differential diagnosis where, but there will be no communication with the ventricles as seen in schizencephaly, and there can be mass effects with intracranial cyst. Another differential diagnosis will be a hydranencephaly, wherein both cerebral hemispheres may be entirely or partially absent, with CSF filling that space. And FARCs may be incomplete or absent. So the treatment of schizencephaly depends mainly on multiple factors, including the signs and symptoms and severity of the condition. Treatment generally consists of drugs to prevent the seizures or physical therapy. Management is mainly supportive, which includes rehabilitation for motor deficits, intellectual disability, and seizure management. Surgery can be a choice in cases with hydrocephalus or raised intracranial pressure. In vast majority of the cases, this is a sporadic condition, but familial occurrence has been reported as in our case. So to summarize, the most common location would be usually Sylvian fissure and involving frontal lobe and parietal lobe. And it has been shown to have association with CNS anomalies like absent septum pellucidum, septo-optic dysplasia, polymicrogyria, and heterotopia. Differential diagnosis will include poroncephaly, intracranial cyst, hydranencephaly. Neurological outcome mainly will be in the form of seizures, intellectual disability, hemiparesis, cerebral palsy. Prognosis, if it is bilateral or large unilateral cleft, there can be poor prognosis, and small open schizencephaly without involvement of sensory motor area can have good prognosis. So to conclude, schizencephaly is characterized by a full thickness cerebral parenchymal cleft lined by gray matter. In type 1, that is a closed lip, the lips of the cleft are in contact with each other. In type 2, that is the open lip, the lips of the clefts are separated by space filled with CSF. And detailed history and ultrasound examination for additional CNS and systemic anomalies is warranted. Multimodality imaging with both ultrasound and MRI for prenatal diagnosis of schizencephaly whenever feasible. Also, genetic testing is advisable on case-to-case basis. Thank you for your time.
So thank you, Divya, for this wonderful presentation. A very rare case, bilateral schizencephaly, recurring also into consecutive pregnancies, right? In a non-consanguineous marriage, and wonderful work with MRI. And happy to know that the baby is doing well. So now we will start the discussion part, and I invite all the experts from SFM Kerala chapter to join, this discussion. And we will take up the questions first from the chat box. So this question is for Guhaprita. What is a PCPNDT procedure to report hypospadias, probably any genital anomaly on prenatal ultrasound? Are we allowed to report it prenatally?
Yes, sir. In PCPNDT Act, there are provisions to diagnose sex-linked disorders by ultrasound and invasive procedures, but it's always a worry to face legal litigation. So what I did for this patient is, when the suspicion came, I brought this to the hospital management, and they discussed with the district PCPNDT council, and when they gave the nod, I was allowed to report it. So it might change from place to place. So it's always better to know the norms in that district and follow accordingly.
Thank you so much. I would like to ask Khurana sir for the situation in North. How's it? For such anomalies where the PCPNDT is a challenge.
Yes. So thank you indeed, and congratulations for this absolutely phenomenal evening with these marvelous discussions. There have been some excellent presentations, and I'm so proud that the young guns of Kerala have kept up the flag flying so high. Now, when it comes to the PCPNDT, it's very straightforward. It is very individual based. The PCPNDT law clearly states that in these situations, we will obviously declare the sex, and it is well within the law. There is no question about the law. The interpretation of the law is completely dependent on the bureaucratic spider web that happens. So, and it's not just a question of north or east or west, it's a question of district to district. So if the district appropriate authority decides that they want to make a fuss and not understand the situation and separate science from governance, then they will obviously give everybody a hard time. In Delhi, of course, we're very lucky. We have a very understanding district appropriate authority, but that does not apply to most districts. Let's face it, the lower bureaucracy in our part of the world just refuses to evolve, and it seems to be more for commercial benefit than for anything else. And it's not that I'm making an accusation in public, but the fact is that the amount of hassling is just too much to handle. For most young people in fetal medicine today, I don't think we have the grit all the time to handle such problems. So we have to strike a balance between reality and law and science. Law and science are very straightforward. We declare the sex and it is straightforward, it is within the law. Reality is that it can lead to untold hassles, and we really have to be very practical in making sure that we don't get into that vortex of these hassles. It's like a whirlpool where we always seem to get stuck. So we really have to consider the local psychological environment rather than anything else.
Alok sir, would you like to throw some light on this?
We've had this discussion many a times about how to disclose the sex-linked abnormalities, especially the anomalies of the genitalia. And I totally agree with what Khurana sir has said, and I always follow his advice: be non-committal as possible, and try not to disclose, because somewhere times it can bite back. So my practice, if I encounter such abnormalities, I generally, on paper, I would write as ambiguous genitalia.
Right. So, Dhuprita, there is a question also. We will come back with the discussion. This question is, how did you assess the phallic length? How did you know it's a short penis? Did you use any nomogram for the same while you were doing the prenatal examination?
There are various nomograms available, sir, but the problem is there will be fetal erections which will happen 1 to 3 times per hour. So that might vary. So generally, for nomogram at around 20 to 22 weeks, the length when measured in the axial plane from the tip of glans to the scrotal base, base of penis at the level of scrotum will be normally 7 to 9 mm. Anything less than 4 mm can be considered as micropenis between 20 to 22. And at term, the length of penis will be 2.8 to 4.2 centimeter. There are nomograms we can follow, but these difficulties we might face. But generally, it is like based on the overall look of the penis, how it looks, whether it is curved and all those things we will look at.
So while you were counseling the parents, the expectant parents, what was the response while you were counseling about this condition, genitalia ambiguous? You don't know 100% sure it is there. So how did they take it up?
Fortunately, this couple, mainly the mother, was very much understanding. When she came, she was 30 weeks. She was like, whatever it is, if it is correctable, I'm okay with that. And I put forth that this is my suspicion. It may not be there also. Because this was the first case which I am reporting. So that patient was very much understanding. Luckily, that part was easy for me to counsel them.
All right. So did you, have a pediatric surgeon in your team while for multidisciplinary counseling? Did you send them to, one?
Yes, sir. Yes, sir. We had a pediatric surgeon. We sent them there and they counseled like postnatally. We can find the type of hypospadias and decide the timing of surgery. Now also they told as the stream is normal, whether the baby might need surgery or not, we will decide at 1 year by looking at the length of penis at that time.
I think Vidya ma'am wants to say something on this.
No, this is way back before the PNDT law was so flexible. This is a patient who has severe FGR where I did a karyotyping and it came as 9p deletion. And looking at the scrotum and the penis, it just was like a cordy with a very small penis, but those days we were not even allowed to talk about it 9 years back. The baby has born with hypospadias and neurological disability, and anal opening was not patent. So multiple small things. So the next pregnancy, they were very aware that this can be there, and then I did an amniocentesis and it was fine. But when I reported this 9 years back, as Guha mentioned very clearly here, that it depends upon the center also. People are not very happy to hear, first of all, that I have told about a small penis. Second is the family would directly go for termination of pregnancy immediately when you tell something like this. So it was a 24 weeks. Then there was no liberal law, and then nobody allowed me to speak about the penis then. I documented in the sonocare where it is a hidden comments, and explained to the family and to the obstetrician and the neonatologist so that there was no shock when they saw the baby. But it's an absolute nightmare, as Guha said, that it's very difficult to tell them that this may be, may not be, but it is there. When you literally see a hypospadias, you cannot miss it. If you look at it, it is short, then you cannot miss it. As she mentioned, you can even measure. But telling is more traumatic than measuring and seeing, because we are not sure about whether it is there or not. And this 9p deletion is first time I was seeing then, and then when we read about it, there is association with FGR and neurological damage and hypospadias.
Right. Thank you, ma'am. Vivek, you want to give some inputs on this?
Well, hypospadias, I think the diagnosis isn't difficult, as Vidya ma'am just mentioned. I mean, you see, you document the genitalia in every anatomy scan that you do, and suddenly some cases catch your eye, and you feel that this is not how it should be. So then you look further and you measure, and you can objectify your diagnosis. So diagnosing is not the difficult part. Reporting, what we do here is we just mention that the external genitalia needs to be reassessed after birth, a very non-committal statement, and we tell the parents that this is what is happening. So we have not documented that the sex has been revealed, but we tell them that this is the condition. We think it's a male baby. This is what we are seeing, and in the report we'll mention that the external genitalia needs to be reassessed after birth, so that they don't point fingers at us.
Jyoti ma'am, what about certain X-linked conditions? Like in a previous pregnancy, there are some X-linked conditions, and and they come for a new pregnancy. So in that case, are we allowed to, disclose the sex of the fetus, and probably tell the fetus is going to be affected or not?
Yes, as long as you have a genetic diagnosis or genetic confirmation, I think PCP and DT will allow you to disclose that. It's only when you suspect and you're not sure about that. Just like Vivek mentioned, that's exactly what I would do. If there is a concern, and if I think it is just hypospadias, which does not require termination, I would tell them that there's something wrong with the gender. We need to have another look at it, but it's not something major. And I will definitely ring the obstetrician and tell them that this is the problem. And I'll document in my notes, but not in the report which I give to the patient. But the patient and the doctor will be on the same page so that they can have a good look at the end of delivery.
Okay. Prashant, do you want to add something?
Nice presentation, Guha. I would like to add one point, like on the progesterone part. Though the earlier generation progesterone was blamed for causing such like the 19-nor steroid ones, but the current evidence clearly says that the newer ones doesn't, at least like in evidence, doesn't cause the such like hypospadias or whatever. And it will be quite difficult for the doctor also, like if he put such a statement that she has given such a drug and caused a defect, rather like it will be like a blame statement, like making it like an iatrogenic one. So otherwise, I think very, very nice presentation.
And I think she added the name of the progesterone because I wanted to know that the type of progesterone. Please don't blame them.
Corona sir is.
I think Corona sir wants to, put up some final words on this.
Getting back to your question, Sinish, for all the Duchenne muscular dystrophies, I always do a sex determination at 13 weeks and only then go ahead with the CVS. And we do it only on the male fetuses, and we don't do it on the female fetuses. And that is completely accepted by our state appropriate authority.
All right, sir.
And there are several such rarer conditions for which we do sex determination at 12 weeks, 6 days, 13 weeks, 1 day.
So, Goprita, how confidently can we, confirm the gender of the fetus in the first trimester?
Literature says it's up to 70% by this angle of the angle sign. But the more than 99% confirmation can be done only in the second trimester. So that is by the angle of the angle when the genital tubercle, there's an angle between the lumbosacral skin surface and the genital tubercle. When it is 30 degree or more, it is a male fetus. Less 10 degree or less, it will be a female fetus.
Right. So I think we'll go to Shruti's case then. Yeah, Shruti, you have a question there.
Yes, sir.
Basically, it is to depict an image. I'm not sure whether you have that image with you right now. It is,
Depiction of normal
yes,
dural
yeah, the
sinuses.
dural venous sinuses in the normal fetus.
I
If
don't
you
have the image, but if we try and look at the, if you want to look at the dural sinuses, maybe if we reduce the PRF and the wall motion filter, we may be able to see the major venous sinuses. Those are the superior and the straight sinuses. We may be able to visualize those sinuses. Unfortunately, I don't have the picture of the normal dural sinus.
These venous sinuses were excellently depicted by Dr. Prasanna Roy in the Next Gen webinar, which happened, just a while back. And in due course of time, it will be put up on the YouTube channel of SFM. And you can all see the excellent depiction of venous anatomy in his talk.
Yeah, I think if I can add to that, if you take a mid-sagittal plane and bring down your PRF scale or use slow flow, you can beautifully demonstrate all of the venous channels of the brain, including the superior sagittal sinus, the vein of Galen, the inferior internal cerebral vein, the straight sinus that drains it into the torcular, and then goes down from there into the transverse. So it can be depicted with the appropriate color flow setting.
Vivek, can I ask you? Sorry.
Yes, ma'am. Yes, ma'am.
No, no, I was just asking why did you terminate that pregnancy when she touched upon your OP at 20 weeks? And why was the waiting period of another 3 weeks to look at what is going to happen in the head?
Yeah, because the natural history of dural sinus malformations are quite unpredictable. Even though we were seeing arterial feeders there, suppose there is a thrombus that develops. See, even the hyperdynamic circulation is because of the arterial venous shunting. But these arterial jets can cause abnormalities in the endothelium lining of the veins, and this can lead on to thrombosis. And some thrombus can occlude the arterial feeder and can occlude the vessel, and the thrombus can result in a shrinkage of the size of the dural sinus. So they were willing to wait till 24 weeks because they had that window. It was a very precious pregnancy. And this was the time that we had the workshop. So Dr. Karina was coming from Israel, so they also wanted to get her opinion, which is why we waited for another 3 weeks. Otherwise, we would have terminated at 20 weeks itself. Yeah.
All right. We'll come back to this case. So Basil, you have a lot of questions there. So let's go to the normal one. Are there any specific settings to visualize the X properly on the color mode? And probably do you look at the X in each and every case?
Yes, so nowadays definitely I'm looking at the X for every case, not just the X. I'm even looking at the branching pattern, the left portal, the 3 branches, the right portal, the 2 branches. In fact, I'm screening the entire venous system nowadays. That's a different story. But then for routine scans, definitely you have to look at least the X to just make sure that the portal system is intact. That is one. I have towards the end of the presentation, I have showed exactly which plane that you have to focus to get that X. It is the plane at which you get the DV in that axial plane, and then you angle it slightly caudally, maybe 1 to 2 degree caudally. You will get that X in which the main portal vein is coming and joining the portal sinus. Now, any settings in which the PRF is reasonable, like it has to be slightly lower than the DV plane, in which DV PRF, in which you are able to see the umbilical vein and the branches. That should be fine. I think a proper side transverse axial, that inclined one, that you should get the portal system completely intact in just one axial plane. You need not look at any other plane. In fact, you even see the splenic vein draining into the SMV and then joining. So I think I showed you in one of the pictures in which that one plane shows everything.
Correct. Jyoti ma'am, you want to say something on this?
Selling, it's a very good practice to look at every case, because in ultrasound, unless you know the normal, you cannot pick the abnormal one. So it's a pattern recognition. You keep looking at it so that when you look at the abnormal one, it will raise an alarm. So I think it's a good practice.
Very good point. And one more thing for the beginners and the juniors who are present here, when you have any DV abnormalities in the first trimester scan, you don't see a DV properly, you have some difficult tracing where you're not seeing a good sagittal view, a good DV, or in any conditions when there is a severe growth restriction or high drops, make sure that you look at the portal circulation also, so that you get this extra information where you know that you have to plan or prognosticate the baby's conditions postnatally, or to even plan a TOP or deliver in a tertiary care center, to look into even to the level of transplant for them sometimes.
Basil, I'm curious. I'm curious to know why this was suspected in the first place.
Sir, this was actually the initial suspicion was by Dr. Sara, who was there with us. So what she found was when you're taking the AC plane, the abdominal circumference plane, stomach is seen, adrenal was seen, but the C of the portal sinus was not clearly seen. So from there it started off. The entire search for the quest for diagnosis started off. So at a point taken as if you just stick to the basics, even with basic planes itself, probably you will pick up all these abnormalities.
Yeah, but basic
There's
plane
a
with an
question.
additional.
Please continue, Vivek.
No, I just said basic plane with an additional color image. Yeah.
Yes.
Because routine abdominal circumference, we don't switch on color.
Yes.
When you go down, as you said, and switch on color, then you might suspect that something is wrong. Either you don't see the X or you don't see a normal C curve, then you start to suspect something is wrong. But great pickup, amazing pickup.
Yeah, amazing pickup, Basil. Do we offer amniocentesis for isolated umbilicoportal system anomalies? What's your take on that?
When DV is involved, something starting with DV, then we offer, but otherwise we offer, that's a different story. But then all papers, everything that say that there is no increased association, but honestly, we give that option.
But Basil, definitely the association of rasopathy is more in these patients, no, right? You have to just look at other rasopathies also, even if you're not talking about 13, 18 and all. But like Noonan and other things also should be looked at in all these shunt anomalies.
Yes.
Are people not talking about whole exome sequencing in these patients, but at least we have to offer them definitely.
Understood.
There's a question, what is the postnatal significance if the right and the left portal veins don't connect?
Sir, the significance is only when there is a portosystemic shunt. So it depends, whenever there is a shunt and the blood from down below, the portal blood is bypassing the liver and entering the bloodstream, definitely the ammonia is going to go up. So as long as there is no shunt and it is going, some part of it is going into the liver and only that part is coming back to the systemic circulation, everything is okay. So what happens is, when there is no connection, the left part is completely supplied by the umbilical vein. Now, after delivery, this umbilical vein is not going to supply and DV is going to shut off. So this entire part, they won't be getting enough blood supply. So it is going to go for, atrophy or, shrinking in size. And the other one, as long as the right portal vein, which is there, which is supplying the whatever the major chunk that is there, that will definitely take over the complete liver. Now, in this case, we think there is a connection from the right portal vein back into the left liver. So that anatomy has to be delineated. But then there is the significance is mainly when there is a portosystemic shunt. The shunt is the one that will decide whether the baby will need liver transplant, baby will need any ablation procedures. All of them will depend on the ammonia level. So simply just monitor the ammonia postnatally. Perfect.
Khurana sir and Alok sir, any final words on this particular scenario?
So the portal venous anatomy, it is very, very variable. Okay, so there are many instances in which it can be the anatomy is altered, it is unusual, or some branches may be absent. So majority of these cases, they will do well. Nothing much is going to happen. It is the cases in which there is complete absence of the portal venous system. They do not do well. By the time they reach 9, 10 years of age, they will develop cirrhosis. Rest of the cases, liver is a very resilient organ. It manages.
Khurana sir?
There is one major confounding factor in these, because of a Chinese publication that came up about 5-7 months ago on the association of genetic observations on deep exome sequencing. Because of this paper that has come up, we unfortunately now have to actually offer amniocentesis to all of these, irrespective, because of that one paper. Because tomorrow they can challenge us and say, look, this existed and you didn't do it and we lost the baby. And we didn't lose the baby because of the abnormality. The abnormality could have easily been there, and you have so many abnormalities on a deep exome sequencing, which are of no consequence. And yet you get stuck in a legal situation. Therefore, it becomes necessary, because of papers like this, to then do a rethink. So what I'm doing now is to actually tell the patient that, look, there is this one odd paper. You want to take the chance, you do it. Most of the time, we've been managing pretty well without this. But if you want to attach importance to this, I'll go ahead and do an amniocentesis for you. And then we do it at whatever time we discover these. If, of course, we have a suspicion at 12 weeks, I call them back at 17 weeks, because 17 weeks is when I do all my amnios, because the DNA is much better. And so I get better results from an exome sequencing. But if it wasn't for this paper, I would really just not do anything about most of these and just leave them to chance.
Thank you, sir, for those wonderful inputs. And Sumya, you have a question there. So, like, what are the any antenatal signs that have been proposed for infantile hypertrophic pyloric stenosis? And can hypertrophic pyloric stenosis be diagnosed in fetuses?
The hypertrophic pyloric stenosis is usually a postnatal diagnosis. That is, it is suspected only when that baby develops non-bilious and projectile vomiting. And maybe sometimes we can keep a high index of suspicion when we see a large stomach or polyhydramnios. Same findings only we saw in atresias also. There is no specific sign to diagnose pyloric stenosis.
So I think in your case, when you saw those findings, you had a high degree of suspicion of pyloric atresia, and then when
Yes.
I think the pediatrician was vigilant at birth, right? To
Yes, sir.
yeah.
Yes, sir. Yes, sir. Yes, sir.
So Parvati has a question there. Can epidermolysis bullosa be suspected on ultrasound? Because you mentioned about an association between both this.
Yes. Usually it's a skin blistering disorder. There are no specific signs on ultrasound. But if we have a high suspicion, like if there is a family history or if there is a previous baby with pyloric stenosis, then when a second baby or third baby develops this, we can suspect that there might be a link. So there is nothing specific to be seen, but usually we can see echogenic particles in the amniotic fluid in ultrasound. And sometimes in MRI, if MRI is taken, we can see dependent layering debris due to the sloughed of skin. And it might show intermediate signal intensity on T1 and T2 sequences. Apart from these, there is nothing specific, sir.
So Manishi say, yeah,
So
yes, ma'am. Please,
it's
please, ma'am.
thickened pyloric muscle and muscular thickness of 2.1 millimeter around 22 weeks. There's some nomogram which was in one of those papers. There's an answer to, if there is an answer to Sumya's question. I've never measured it before, but because I saw the question, I was just looking at it. So just thickened pyloric muscle, normal mean pyloric canal length is 5 millimeters. Muscle thickness of 2.1 millimeter at 18 to 22 weeks is mentioned.
Okay, ma'am. It would be nice if you can share that paper to us, probably in this chat box. Vivek, your inputs on large stomach in third trimester?
The other clue, we've had 3 or 4 cases which you've reported. So in that, all of them, what we found was beyond 26, 28 weeks, if you, from the axial view of the abdominal circumference in the big stomach that you see, you turn sagittally, you can see the distal gastroesophageal junction also filled up with fluid. So that is another additional finding that you can use to, because sometimes you're just confused whether it's just a large stomach, because stomach is a dynamic organ, keeps filling and emptying. But if with the large stomach you also find that the distal esophagus is dilated with fluid, then that is a very clear sign of atresia at the pyloric level. So much more evident later on in gestation. Couple that with polyhydramnios, you find these 2 findings, and it's a very clear giveaway to pyloric stenosis. We've had 3 or 4 patients. I think 3 out of 4 of them were from Maldives. So there are pockets where this is endemic. So you would suspect when you find a large stomach with a dilated GE junction, if you look for it in the sagittal or the coronal planes, you might see it as well.
Purana sir, your final inputs on this particular case?
You know, it is so difficult to be absolutely sure of what is a dilated stomach and what is not. And even if I were to take a 2 millimeter reading, if I was biased, I'd make it 2.9. And if I was unbiased and I said, why put my foot into it? I'll make it 1.8. I mean, let's face it, it's human thinking.
Yeah.
So what I typically do is to review them in a week's time and just handle it that way. And I do realize that, look, every time I suspected that there was something wrong, the baby didn't even bother to vomit after it was born and just let me down completely. So then, I mean, that's just not fair. So the best thing is to just leave these alone. Anyway, we would diagnose them only after 28 weeks. And if we were doing that, then we just wait for a few days and they'll be quite happy. And sometimes there's these swallowed particles which just remain stuck there. And with the first feed, they pass on and there really is no problem. Or you notice that after the Ryle's tube has been passed, because you made so much of noise, they did aspirate something from that Ryle's tube, but beyond that, nothing else came out and the baby took the next feed pretty well. So the outcomes that we have followed up have been so not in favor of making an antenatal diagnosis that almost all that we ever diagnosed turned out to be normal in the long run, except for one web. And that was the only one I've ever seen, and that was like 15 years ago. One web in one's career doesn't really mean that we should make noise about it.
Thank you, sir, for those inputs. And I think we can throw one question to Divya. You have from Chelapan Karupia. Why did the medical board did not give termination for, give permission for termination of this pregnancy? What was the rationale to allow continuation of this pregnancy?
Actually, that was really unfortunate, sir. So it was a really big dilemma. She had come to us at 31 weeks and they wanted termination of pregnancy, and we had sent the patient to the medical board also. But then, as you know, you might be aware, like, you know, the local situation. So the board did not allow for termination. Now they have to, like when I spoke to the patient postnatally, now the baby has so much motor developmental delays and all. So that is really unfortunate. So I mean,
So I think just like the PCPNDT Act, there is a lot of variations in how this termination, the board is offering the termination of pregnancy, is approaching such cases in third trimester, I think. Jyoti ma'am, you want to put some inputs on this because we have faced some situation in our areas. We have referred several cases to Medical College Calicut without any response from them.
Yeah. It's clearly unfair because a fetus with bilateral schizencephaly, just because the baby has crossed 30 weeks, was denied termination, which is unfair, which has been happening in our part of the world because when we come across abnormal conditions which are more than 28 weeks, where they think that the baby could survive when they're terminated, they will refuse termination, which is unfortunate. And I think I had a word with Ashok Rana sir earlier, and I was told that in such situation we can actually do fetal reduction and deliver the baby. But somehow it is very hard to convince the authority here, and we've been struggling.
Last week, sir, I had a very pathetic situation. It was severe ventriculomegaly. The whole brain was full of fluid. The family came for termination of pregnancy, but it was 33 weeks. They had a court order with them, which clearly says the baby should be delivered and should be given every possible modes for treatment postnatal. So how do you do a feticide in that case?
Yeah. So basically, the way we escalate matters from a medical board is to take it to the High Court.
This is a High Court order.
Then the High Court can be challenged in the Supreme Court. And anyway, we will still get our diagnoses before 37, 38 weeks. And then by the time it reaches the Supreme Court, it always has to be looked at by people who are from the profession, and therefore they will look at it quite differently. Sometimes, yes, even experts can be whimsical, but that is the way we appeal in these situations, and it seems to have worked a lot. Because of the confusion in this business of reduction, the technical word is induced fetal demise. So the law is something that tells us what can be done. Once the law gives us permission to terminate a pregnancy, the next question is, how should it be done? How should it be done is to be made on the basis of either notifications from the Ministry of Health and Family Welfare or from guidelines from the profession, such as an RCOG guideline or a Society of Fetal Medicine guideline. And we do realize that there is an ambiguity here that people are exploiting. And so we've decided to put together a panel that will give a position statement on induced fetal demise, and that every fetus that is going to be delivered after 26 weeks of gestation age will have to have an induced fetal demise before delivering it. So then this becomes a referral document for everybody. Once that is in place, then I guess it's very straightforward that you have an academic organization that is an apex organization that has given these guidelines, and we have to follow the guidelines. Then all the ambiguity will be over and done with.
When will this happen, sir?
As soon as you agree. You have not replied to my email.
No, we didn't
So
get any.
there are a set of documents which we unearthed because we had a couple of cases in the last couple of months.
Right.
All of them came through the High Court. So we dug up a few documents. So we found a confidential document which is a directive from the Ministry of Health and Family Welfare, Government of India, to whoever it is supposed to be conveyed to, that you can very clearly do an iatrogenic fetal demise before terminating before a late termination of pregnancy. We also dug up a guideline from FOXI which lists the number and name of the conditions which are eligible for or considered as because the law now says significant anomalies. So FOXI has listed out what are those significant anomalies in their guideline on late reduction as well. And you can also use the RCOG, which clearly says any reduction after 24 weeks has to be done after iatrogenic fetal demise. So we presented all of these three documents through the court, and now we have a standing advocate who will take all of these cases for us. And all of those cases after that, we have been getting court orders which specifically mention you can go ahead with potassium chloride injection and then deliver the baby.
Correct. And the 2017 notification is a public notification from the Ministry of Health and Family Welfare. And in fact, it was a combined effort of FOXI and the Society of Fetal Medicine. And this was then sent to every single state, and all the states had endorsed it at that time. Because, health is a state subject, not a central subject. So the state has to endorse it, and all of them had endorsed it. And
the problem with our state is we do not have a statutory medical board as yet. So that's where the confusion comes. There's no statutory medical board.
Precisely.
But what was discussed in the last meeting that we had was that you can actually, even if you're a private center, you can apply for a statutory medical board license, and you can conduct your own medical boards with the relevant specialists involved.
Absolutely true. So actually, there is no such thing as a statutory medical board. A medical board is something that can be appointed by any medical superintendent of any district hospital by keeping the rules in mind, which is one female, one social worker, one pediatrician, one fetal medicine specialist, and one radiologist at the minimum, and whomever they want to add. So technically, it is not a statutory medical board. It is a specially appointed medical board for this purpose. So this clause that people have been trying to pretend exists does not exist. There is no such thing as a permanently appointed medical board. It is constituted on the spot or for any complaint or any request that is received.
No, but does that have to be a government hospital, or we, like for example, Amrita is a teaching institute? Can we constitute a medical board, and does that have any legal sanctity?
No, that is not within the legal framework.
Yeah.
It has to be a district hospital. That is the level which is defined.
No, but that's where we have the problem, sir. Very often we had a case which was diagnosed as we diagnosed it as an antenatal infantile Marfan syndrome. So we sent a very, very bad condition with 100% mortality. We sent to the medical board. They said Abraham Lincoln had Marfan syndrome, so you cannot terminate this pregnancy. They don't understand the diagnosis in itself. So that's where we face a problem.
Yeah, I think
so the last two cases, what happened was the High Court specifically instructed Amrita to constitute a medical board and then take a decision.
So then it works out perfectly well.
Yeah.
But you can't have a permanently constituted medical board. Yeah.
Okay.
Yeah. And there is no such thing as the statutory
medical.
Yeah.
Okay.
Bijoy, your inputs on this discussion? We had a couple of cases where there was a anomaly with a poor prognosis in third trimester, and none of the boards offered the
It's-
approval
it's-
for termination.
We also face the same problem of getting late terminations done, but we always make it a point to put in KCL if we are doing late terminations. And sometimes we do get references from medical colleges itself for us to put the KCL and send it back if they get a medical board this thing on doing the termination. But otherwise, it is difficult, and it's a difficult thing to do. And sometimes it's when you have a very late termination and you're sure that the baby will not survive, it might, and if suppose it's like 34 or 35 weeks or something like that, then might as well allow them to deliver and then not do anything to try to revive the baby. That's also something we do in certain cases. So one case that we had recently was a very late onset arthrogryposis, which came in pretty late, and there was nothing we could do. So we just allowed the pregnancy to continue, deliver, and we did not resuscitate, and that baby did not survive. So I think in certain cases we might just have to just wait and watch rather than trying to actually try to create demise and then go in for delivery.
Okay, thank you.
Yeah,
Thank you, Bijoy.
I think I've located that. If I can share one of my PPTs, do we have a few minutes, or should I just share it on the Kerala group? This question of the. Are you able to see my?
Yes,
sir.
Yeah.
Yes,
Let me
yes.
just share this and go to full screen, and so this is it. This was that notification, and it's 14th of August 2017 from the secretary in the Ministry of Health as part of the National Health Mission. And it was issued, and then again, the mission directors were reminded about this by the Joint Secretary in 2018, which is the second one that I have put here. It also went on to give us the information on the second part, which is this. What all is supposed to be done, and then it specifically mentions about the method, and then after that, including a pre-anesthesia checkup, and then the list of major fetal abnormalities was an annexure in this particular one. So both these documents can be used in the court because they are actually issued by the Ministry of Health, Ministry of Health and Family Welfare. So this is what we should quote, and I'd put them on the group so that all of us can use that. And this is the actual reference in cases of pregnancy over 24 weeks of gestation and ultrasound guided procedure, blah, blah, blah. And this is the paragraph that says so, including the fact that we have to observe for 30 to 60 minutes for asystole.
But sir, the High Court lawyer and the judge should know about this, no? They are
Yes.
supposed to
No,
know
you
this
should
before they
produce
issue
this.
a
You can
statement.
produce this document.
I
You can
think you
produce this
have
document.
to produce this in such a way that they get, we have to advertise this, of course. And I thought we'll put it all together in a SFM guideline, which we will release at BasicCon this year, because it will take us a few weeks to put that together. And so, including that, a repeat of the list of all these processes. So we will put that together and then release this. But this is already a government document. And it clearly said that, look, this is to be done
Please
by
share, sir.
under
Please share.
professional guidelines. Yeah.
So please do
It
share
was shared,
with
madam.
us.
It was shared in our obstetric workshop group. So I'll share it again in the group if you haven't seen it.
Yeah. It's
Yeah.
and then both
This in the
documents-
Foxy guideline is also there. So I'll share both of these in the group as well.
Yes. Yeah.
And the RCOG guideline with the relevant section highlighted.
Yeah. And sometimes they insist that you should have an Indian guideline. So this is a ministry document. It was a notification.
Okay, so thank you everyone for the wonderful discussion. And I think there are a lot of questions, and there's request for a lot of normal images as well as the articles that we were talking about. Probably we can share in the SFM group later, and it's already a little bit late. So I invite the president of the Society of Fetal Medicine Kerala chapter, Dr. Jyoti, madam, to say the final words.
Thank you, Sinesh. Good evening, everybody. I'm really excited to see that it's still 164 members watching this program in the 10:15 p.m. At the outset, I must congratulate all the speakers, brilliant speakers, for the presentation. I think all the five did a wonderful job choosing the unique cases, as well as showcasing their talent by giving good images and video clips as well. And I must thank Sinesh and Dr. Alok for guiding them properly. And thank you all the panelists, all the experts here, especially Dr. Vidyalakshmi and Vivek, who've been there throughout the program. And I think take this opportunity to thank all the delegates for watching this. Thank you very much.
Thank you. Thank you, everyone.
Thank you, Karanna sir. Thank you all the SFMT members, Jyoti and Sinesh. Wonderful job done. And everybody who's gathered, and now it is almost 10:15. And that shows the credibility of the society, Ashok sir. And thank you all and have a good weekend.
Wonderful.
And I want
Bye.
Good night. Thank you so much. Wonderful.